I'm honored to introduce Dr. Quinn. Uh, uh, well, Dr. Quinn is a professor in our department, and he's been with us over a dozen years, plus a dozen plus years. As we know, he came from MGH, where he completed his fellowship in consultation-liaison, medical school at Harvard Medical School, and undergrad at Princeton. So he has the right credentials. But more importantly, he has really excelled within our department. As we know, he is not only the division chief for consultation, he's also the vice chair for adult clinical services. And as we have the habit here in the department that when we need to cover, we kick things up. So when there's been a need, he always covers clinical services. But in addition to that, he continues to do research, very productive from the point of view of getting grants. I've mentioned this before, I'm going to repeat it. He recently got a grant for $6 million. And this is at a time when getting grants is more difficult than ever. Now, Dr. Quinn has a number of expertise. Of course, he's going to talk to us today about TMS. I always ask him to let's get a fellowship or a T32 in interventional psychiatry, because with him and Dr. Abbott, we have literally the leaders in the nation. In addition to that, he has a lot of other expertise working closely with residents. Actually, I was having a conversation earlier this morning with Dr. Crisanti about a project in Catatonia, if I would be willing to work with a resident. And I mentioned to Dr. Crisanti, I'm the wrong person, because we have the national expert in Catatonia, Dr. Quinn. Also, recently we were looking at our reputation in the community. And we are number one, as I mentioned in faculty meeting, over Presbyterian by 15 points. And in addition to that, we recently climbed a very nice slope in terms of the best, I guess, providers in an area. And we jump over Presbyterian. Sorry, Dr. Quinn, it was thanks to you, because your picture was there in Albuquerque Journal. So as you can tell, folks, I am very proud to be a colleague of Dr. Quinn. Dr. Quinn.
Thank you so much, Dr. Tohen. I'm incredibly honored by that introduction. Thank you. So it's my pleasure to talk to you all about a passion of mine in terms of clinical and research. So I'm going to go ahead and share my slides here. Are you all able to see that?
Yes.
Okay, super. Thank you. So my talk today is Better, Faster, Stronger, TMS for Depression in 2025. This is, of course, a reference to the famous Daft Punk song. If you're into electronic dance music, I think you'll recognize it. And really to sort of say that TMS is, in fact, better in 2025 than it has been. It is, in fact, faster. And we're looking at ways to make it even more stronger, more robust, more efficacious. So I'm going to talk about all those things. Let's see if I can get the slides to advance. There we go. This is my grant support. Dr. Tohen is very kind to announce the grant that we just got a few months ago called Preempt, Precision Phenotyping of Behavioral Risk and Response to Electromagnetic and Psychedelic Therapies. Working with a number of other department clinicians and researchers on this multifaceted program involving TMS, psilocybin, neurofeedback, and AI and deep learning to try to better understand and treat risk of suicidality. So today I'm going to talk to you about current best practices for TMS for depression. We'll talk about to the degree that fMRI guidance is beneficial for TMS and depression. This is a very exciting area where we're probably going to have the definitive evidence come out later this year. And we'll talk about what the evidence base is currently. And then what role can neuroplastogens, which is a brand new word for me. I did not know this word from a few months ago. What role can these agents have to improve the efficiency and efficacy of TMS for depression? So this is just a case to illustrate the type of patient that we typically are treating on our clinical TMS service, a 60-year-old female with chronic depression since early adulthood, who has chronic symptoms of low mood, anhedonia, guilt and low self-esteem, low motivation, difficulty focusing, low energy, often with intermittent suicidal thoughts. So pan-positive for neurovegetative symptoms. She's tried multiple trials of antidepressants through the years, more than 15 antidepressants, none with lasting benefit. Psychotherapy has been ineffective at ameliorating her depression. Ketamine has been tried, but unfortunately, although it resulted in a positive effect, was too expensive for her to continue. And she even tried ECT, but unfortunately had significant cognitive side effects and was not able to continue with the ECT. She, in fact, had tried TMS already back in 2010 and did not respond to that at that time. So this is a patient who is quite typical for us. Has been considering or has already received multiple neuromodulation psychiatric intervention therapies and is wondering, well, what type of therapy comes next, or have I really reached the end of the road as far as treatment for depression? So our current practice of TMS for depression, TMS is well understood in terms of its physiology and its physics. It modulates brain activity through electromagnetic induction. A current is run through the figure-of-8 coil that you see. It creates a magnetic field with this characteristic peaked shape under the coil, and it's that peak of the magnetic field which then is able to penetrate through scalp, skull, and reach brain and actually induce an electric current in the brain. So you have electromagnetic induction of electrical currents in the brain using this technology. It alters cerebral metabolism, it alters cerebral vascular oxygenation, and it alters cerebral connectivity. We don't quite understand which of these elements is actually the most essential for its therapeutic benefit, but we're starting to hone in on the belief that it is probably the connectivity changes that result in large-scale brain networks from TMS that are the therapeutic element. TMS is currently in the middle of the field in terms of its cost, efficacy, and acceptability profile. You see here on this plot other neuromodulation therapies like esketamine, vagal nerve stimulation, ECT, and even oral antidepressants on there. The height of the box indicates how expensive it is. How far it is to the right indicates how well it works, and how far it is in towards you on the screen indicates how acceptable it is. And so TMS is quite acceptable, having a relatively well-tolerated side effect profile. It's got about a 60 to 70% response rate for treatment-resistant depression. And it costs somewhere in the neighborhood of about $10,000 to $12,000 if you are paying out of pocket, significantly less if your insurance is reimbursing. One of the developments that has allowed TMS to become more efficient, more efficacious is a stimulation pattern called theta burst. Theta burst is a way of delivering these electromagnetic pulses, which mimics hippocampal discharge patterns, which happen in triplet, 3 pulses at a time at about 50 hertz rate. So when you use this type of pattern, you're able to deliver pulses much more quickly without losing any efficacy. So normally TMS has been delivered in a traditional fashion using just 10 hertz single pulse, 10 pulses a second, and the treatments take anywhere from 18 to 25 minutes, or at 1 hertz, and it takes 30 minutes to deliver 1800 pulses. But with theta burst now, we shorten this time of stimulation down to 3 minutes and sometimes even less than a minute. So you can imagine sort of from a patient acceptability standpoint and provider acceptability standpoint, just how beneficial this is to go from having to spend 30 minutes in the clinic to now you're just spending, 3 minutes in the clinic. And you, like I said, you don't lose any efficacy when we go from 10 hertz or 1 hertz to theta burst. It was this study in 2018 by Blumberger et al., the 3D study, which showed that there's non-inferiority between intermittent theta burst, which takes 3 minutes, and 10 hertz, which took 37 minutes at the time. So there was really kind of no difference in efficacy between the groups. So this has led to sort of the rapid adoption and widespread use of theta burst as the predominant TMS pattern, parameter pattern that we use. And we do almost exclusively theta burst at the UNM clinic now. In the last several years, the innovation of acceleration has really taken the field by storm. Acceleration is delivery of multiple TMS treatments a day. Before acceleration, we were doing 1 treatment a day, sometimes 2. Now with acceleration, in particular the work of the Stanford neuromodulation group, run by Nolan Williams, was able to show that you can deliver 10 treatments a day, separated by only 30 to 45 minutes, and you can deliver the same number of sessions that would normally take 9 weeks in just 5 days. And you, in fact, get at least equivalent efficacy rate in terms of reduction of depression symptoms, but now you've cut the time by almost tenfold. You can see here their randomized controlled trial that was published in 2021 demonstrated that people who were getting active accelerated theta bursts by week 4 had a 79% remission rate, and those in the sham group had an only 13% remission rate. So this was really sort of astounding results to be able to achieve 79% remission in a treatment-resistant, depressed population. So this took the world by storm, and most clinics that I know of have started to deliver accelerated theta burst treatments. It was FDA approved then in 2022. That's Nolan Williams there. He unfortunately passed away this year. Real loss to Stanford and the psychiatric neuromodulation community around the world, because he was an incredible innovator in this area. So let me just sort of illustrate for you some statistics from our service, which has been in operation since 2017. What you see here is our first 21 patients from 2017 to 2019, when we were doing just traditional treatments, no accelerated, no image guidance. And what we had was about 62% of our patients getting to a response, which is 50% improvement in bread or better, 62% responding by week 6. Now on our service, where we do accelerated theta burst for the most part, in 2023 and 2024, we had 45 patients come in. Again, this was sort of a typical New Mexico population, a mix of commercial, Medicare, and Medicaid patients. All had failed 10 or more antidepressants. And what you see, percent response here of 66%. And you can sort of see that their depression scores over the 5 days of treatment, first 5 days of treatment, steadily drop from an average of about 18 to an average of 10 by day 5. And so you can sort of see here, compared to what we had previously, we have the same response rate, 62% and 66%, but instead of 6 weeks, it's now 6 days. So we've accelerated treatment, the response to treatment, without any loss of response, by 5 or 6-fold. So this is extremely popular. We're extremely happy with our results that we're getting in our clinic here, and I highly recommend that if you have a patient who you're considering what should come next for their treatment-resistant depression, please consider referring them to our TMS service. Next, I'd like to talk about resting state fMRI, because this is something that has been widely studied, but not widely adopted yet, and it's not clear how much it contributes to efficacy of TMS. So why would we use fMRI to target TMS and where we deliver the stimulation? Well, the field has overall moved from less advanced to more advanced and image-based ways of targeting TMS. The whole idea is that you want TMS to stimulate areas of the brain that are related to emotion regulation networks or circuitry. The best that we could do back in 2008 was to just use scalp landmarks, basically estimating using the scalp where we think these nodes for emotion regulation are under the scalp. We then moved to using EEG coordinates, which was an improvement on just using scalp landmarks, because now EEG coordinates take into account the size and shape of the head. We then started using anatomical targeting with structural imaging, and then moved into functional targeting, first with PET and then with resting state connectivity fMRI, starting in 2012 when the group at MGH, led by Michael Fox, made some important discoveries in terms of the relationships between these large-scale networks for depression and motion regulation. And now, since 2020, we've really been looking at personalization of stimulation targets, so that finding where each person's unique target is based on their functional connectivity. So the theory behind that, just quickly, stems from the work of Helen Mayberg, who demonstrated using various types of neuroimaging that there's an area called the subgenual cingulate cortex, which seems key in all forms of antidepressant treatment, whether it's medications, whether it's CBT, DBS, ECT, TMS. The area whose activity seems to change and have the greatest correlation with antidepressant response is the subgenual cingulate cortex. So the work of Fox et al. At MGH showed that this area, the subgenual cingulate, actually is anti-correlated with the dorsolateral prefrontal cortex. And you can sort of see this plot of the bold signal from a typical resting state fMRI scan as the DLPXC activity in green goes up, or its bold signal goes up, the SGC goes down, and vice versa. When the SGC goes up, the DLPFC signal goes down, indicating that they are anti-correlated and functionally connected in that way. When the DLPFC turns on, the SGC turns off, and vice versa. So this is what led to this idea that perhaps the DLPFC is a window for us to talk to and stimulate and modulate subgenual cingulate cortex activity. We believe that the DLPFC is part of this frontoparietal network, which pays attention to the outside world. The subgenual cingulate is likely part of either the salience or the default mode network, most likely the default mode, which is more paying attention inward. And as these networks tend to oscillate in terms of their activity relationship to each other. So perhaps the DLPFC, which is very lateral and is very superficial, can be a convenient window for us to stimulate and actually modulate activity in the subgenual cingulate. We think that this actually speaks to kind of the underlying pathophysiology of depression, which is disconnectivity. The work of Williams at Stanford really sort of best describes this, how it's these aberrations in connectivity between these large-scale canonical networks, particularly default mode, salience, and the frontoparietal network, which seem to be at the basis for a lot of the symptoms that are seen in depression. So, and finally, there's plenty of neuroimaging evidence that indicates that when you reduce this connectivity or reduce this sort of pathologic connectivity using TMS, that is when you see the antidepressant response. So the green arrows indicate the pre-TMS connectivity state, generally increased between all these triple network areas, and then the red arrows indicate the post-TMS effect on those networks. So generally a decrease in connectivity. TMS I view as a disruptive type of stimulation that really sort of tends to not enhance or increase, but tend to decrease connectivity between brain regions. So this has allowed us to plot maps of where the depression network nodes are that seem to respond to TMS. And the more the stimulation gets closer to these nodes, particularly the yellow nodes that you sort of see on the top figures, the more you're able to modulate the activity of the anticorrelated nodes, which are the blue-green on the bottom figures. And that's where the subgenual cingulate is. And literature has shown that at the closer you get your stimulation targets in different studies to this anti-correlated area, which is in blue, the better is the result that you see with the antidepressant response. This is the work of Cash et al. From Australia, which really sort of actually demonstrated, that the distance of the stimulation target from the anti-correlated target directly correlates with sort of the antidepressant response. So this is what has led the field to really sort of work towards how can we find exactly where that anti-correlated node is and deliver the stimulation right to it. Let's give everyone fMRI, resting state fMRI prior to their TMS course, find their individualized target and stimulate there. So does that actually help improve TMS efficacy compared to just doing it without fMRI? That is sort of the holy grail study that we're all waiting for. There have been a few non-gold standard studies that indicate that there is some benefit. So for instance, this study from a group in 2025 looked at, I believe this is the Cornell group with, or I'm sorry, the Penn group with Desmond Oates. Compared sort of people who got fMRI guidance with scalp guidance in this crossover study design. People would get 10 sessions with fMRI, then switch to scalp, or they start with scalp and then switch to fMRI. And what they saw was that when people were getting the fMRI guided stimulation over those 10 sessions, their response rate tended to be 68%. Versus those who were getting the scalp treatments responded at a rate of 59%. And this was statistically significant, but the difference between 59 and 68% response, one could argue is that, clinically sort of meaningful. The number needed to treat in order to sort of have one additional person respond would be about in the neighborhood of 6. So for every 6 people that you treat, with fMRI guidance, you would have one more person who actually responded compared to if you did scalp. There's another naturalistic retrospective cohort study by the folks at Brigham and Women's, which showed that of the 115 people who got fMRI guidance compared to 80 who got scalp guidance, of the folks who got fMRI guidance, there was a 77% response rate. And in those who had scalp guidance, 66% response rate. And again, this was statistically significant once they did propensity matching for the folks in each group. But again, one could sort of make an argument, is this meaningful? Is this really sort of worth all the trouble to go and get fMRI guidance to try to get basically, 10, 11% increased chance of response? I can tell you that here at UNM, if we look at our clinical data that I just showed you, and we look at our research studies, which many of our residents and medical students have worked on, and I'm incredibly grateful to them for volunteering on our studies. We have a paper that's in preparation that's going to go out that really sort of summarizes all the work that we've done using accelerated theta burst for depression here. So we looked at about 44 people who got accelerated theta burst in our lab, and 26 got it on the right, 18 got it on the left. We were trying to compare whether left versus right is better. Turns out that they're equivalent in terms of their benefit for depression. And overall, the percent response, the percent improvement in symptoms, depression symptoms, was about 50%, 51%, 49% in the different groups. If you compare that to our clinical population, which never had any fMRI guidance, they're having a percent improvement in their depression scale of 56%. So, although there are some differences in the scales, obviously difference in the protocols, differences in the populations that were in our research studies compared to our clinic, it is noteworthy that with or without fMRI guidance, people seem to be getting about, a 50% improvement in their symptoms across the board. So that's just sort of food for thought here. We're going to wait for sort of the definitive evidence to come out probably later this year. There's an RCT that was completed at another institution. The analysis is underway, so we're waiting to see the publication of those results, probably announced at a meeting, a national meeting coming up soon. But these are just the issues with fMRI guidance. You have to get an MRI, have to have some way to pay for it. You have to have an expert analyze the signals and be able to use modeling to come up with the appropriate spot in the brain to treat. So this is not easy to do, and you definitely need people who are experts in order to be able to get accurate targets. One's resting state fMRI results can be highly variable from day to day. The brain is very dynamic, and it's hard to know how stable some of these targets are based on their methods. Sometimes, you may need to get more resting state data in order for the data to be less variable. And people recommend scanning up to 30 minutes, which is quite challenging to do. Staring at a cross in the fMRI for 30 minutes straight is a tall order for a lot of patients. And there's actually different methods for sort of taking the signal and figuring out where is the most anti-correlated spot in the DLPFC. These different methods have not been compared head to head at all. So even though you may have a method and a way of sort of obtaining this, it's not clear sort of whose method is best for determining where is the target based on the data. So again, the results are, we're sort of waiting to sort of see whether the juice is worth the squeeze in terms of getting fMRI guidance of TMS. Finally, I'd just like to talk with you about this development that I learned about at a recent conference for TMS this summer, neuroplastogen augmentation of TMS. I think this is really exciting and has the potential to change how we practice yet again. It's a very fast-moving field. But let's just take a step back and talk about what are the factors that affect TMS efficacy. So TMS is one of the most rationally sort of designed and studied treatments that we have in psychiatry. We know that demographics affect TMS efficacy. Older age can potentially affect it. The presence or absence of comorbidities definitely makes an impact. The more comorbid psychiatric conditions you have, the less efficacious TMS is. Your level of treatment resistance absolutely correlates with the chance for response. The more failed trials of antidepressants and the longer you've had your depression, the less chance you have of responding to TMS. The target selection makes a big difference. And while we're finding out just how precise one needs to be, when we look at the targets that we were using for TMS 20 years ago compared to now, there's been a massive shift in where we place our coils, and that has led to significant improvement in the efficacy rates of TMS, actually getting it in the DLPFC, getting it close to the subregions of the DLPFC that talk directly to the subgenual cingulate. That makes a big difference in TMS efficacy, and so how you select and locate your target is important. Treatment intensity has been shown to be important. The more pulses you get and the more sessions you get, the better your antidepressant response is. There's a lot of people who don't respond to TMS until their 30th or 40th or 50th treatment. And so those folks, if you had just stopped at 20 treatments, would have been considered non-responders. But the more that we've delivered, the more sessions we delivered, the more pulses we deliver per session, we're now seeing a lot of these people who would have been deemed non-responders in a less aggressive protocol now turn into responders with more aggressive treatment protocols. The dosing for TMS has changed over the years. The field has kind of settled on a convention of the stimulation energy being 120% of motor threshold. And that means that we give 120% of the amount of energy needed to cause your brain's motor neurons to depolarize. 120% is the convention because it seems to be both efficacious as well as safe. If you go above 120%, you start running into an increased risk of causing cortical irritability and lowering the seizure threshold. But the field started off with dosing at 80%. As we moved up to 80, 90, 100, 110, 120, we've seen a steady sort of improvement in the rates of response and remission. So dosing is an important factor. So all of these have been studied extensively. All of these have been optimized for TMS to the degree that our safety limits currently allow. But what's not been explored is this idea of how receptive or plastic is the brain being stimulated. So you can have everything optimized in terms of number of pulses, number of sessions, amount of energy going in, but we don't have a good way to sort of quantify or modulate how receptive someone's brain is to that energy that's coming in. And here's where the idea of neuroplastogens has come into our field, where we believe we can actually make the brain more receptive, more plastic, more changeable with the TMS that's being delivered. We know that based on certain studies that have been done in animals as well as in humans, that some agents seem to augment TMS effect. Stimulants augment TMS effect. It's shown very clearly that people who are on stimulants when they get TMS actually have a higher rate of response and remission. Antidepressants in general tend to make the brain more receptive to TMS. That's why we always tell people don't come off your antidepressants before you get TMS. Your brain is going to become less receptive to TMS and you'll become more depressed and it'll be less likely to work. So we tell everyone continue your antidepressants going in. Other medicines that seem to increase levels of neurotransmitter also seem to have a benefit for receptivity for TMS. There are also medications that can diminish TMS effect, and these are the things that block. So benzodiazepines, by increasing cortical inhibition through GABA agonism, anticonvulsants with sodium and calcium channel blockade, slowing neuronal firing, and antipsychotics, particularly with dopamine blockade. These all seem to have a negative effect on TMS efficacy. And we believe that this is probably it's changing the substrate of the brain so that it's making it less receptive, less plastic. So here's where there's a very interesting work looking at specific agents that can be used besides what was already mentioned to improve the receptivity of the brain. And so D-cycloserine is an agent that has received some particular attention. It's an amino acid analog. It's actually already FDA approved as an anti-tuberculosis drug, which makes it convenient in terms of not needing to sort of go through a lot of regulatory hurdles to get investigational new drug approval to study it. It's rarely used these days just because we have much more effective tuberculosis agents. But it turns out to be, in addition to having bacteriostatic activity, to be an NMDA partial agonist. And so by acting at the glycine binding site, it's able to modulate the NMDA receptor, and we believe that this is how it may exert some benefit for neuroplasticity. It's generally well tolerated. It hangs around for a good long while each time with each dose. The side effects generally are mild, and the only thing about it is that it's difficult to obtain. Dr. Hager and I have been working strenuously to get a supply of D-cycloserine from a local compounding pharmacy, and I believe we're on the precipice of getting it. I don't have confirmation yet, but I've been told that the drug is available and can be ordered. We just need to finalize the details. So we're hopefully going to have a supply of this available to our patients soon. And the reason why I'm interested in getting this supply is because data coming particularly from Canada showing that you can significantly augment response to TMS by giving people cycloserine just prior to their TMS treatments. So this is the work of Alexander McGurr at Toronto and his lab demonstrating that in people who are getting just regular theta burst at 80% threshold, which is frankly a very, very mild, non-aggressive form of TMS, once a day, you can boost their response and remission rates from 20 up to 50% remission. So this is sort of, a 2 to 3-fold improvement in responsivity to TMS. And this was done in sort of a placebo-controlled fashion, which makes it, very trustworthy. And he's actually even studied sort of how does the level of drug in the blood actually correlate with antidepressant response. And there's a very nice correlation between having an adequate level of drug in your blood and having and seeing the antidepressant effect with it. So this is what has led to, I think, probably, when you think that TMS can't get any faster, there's people who just prove you wrong and go, instead of 10 treatments a day, we're now going to do 20 treatments a day. We're going to do all the treatments in one day. Forget this 5-day thing. We're just going to go ahead and put them all in one day. And so this is Jonathan Downer's lab, also at Toronto, using a single day regimen of accelerated theta burst combined with giving D-cycloserine at the beginning of the day, as well as lisdexamfetamine also at the beginning of the day. So 2 long-acting neuroplastic agents. And so patients stay in the lab from 7 a.m. until 6 p.m. that day. And what they saw was that patients would have a significant improvement in their symptoms by week 1. But even after just 1 day of treatment, they saw continued improvement in depression symptoms up to week 6. So even though it was just given on day 1, they were seeing continued antidepressant improvement in depression scores up to week 6. And they achieved a 90% response by week 6, 74% remission rate in this population, which was moderately treatment resistant. But again, an open label study, but just sort of showing kind of the level to which we believe the boundaries of TMS efficacy and efficiency can be pushed. So this is it was very exciting data that we were shown at the conference that I was at in June. And it's now something that if we can get our hands on some cycloserine, that hopefully we'll be able to start contemplating doing this kind of thing in our own clinic. So this was a very sort of rapid run through kind of what I think is really exciting about TMS in 2025. It's already a rapid acting, effective, and safe treatment for depression. Now that we're using accelerated theta burst, the benefit of fMRI guidance is starting to emerge. How robust it is, how much more efficacious it makes TMS is not yet clear. So we're waiting for that definitive data. And then the use of these new agents called neuroplastogens that could augment response, particularly in patients who seem to have, impaired or low levels of neuroplasticity, could significantly change our practice and take a number of people who are non-responders. And like I showed you, the response rate in our clinics, there's still about a third of patients who don't respond. So for these patients, the use of neuroplastogens to increase or augment the chance of response could be a game changer. And I think we're definitely hoping that we can be part of the research milieu that's looking at just how effective this is. So I'd like to spend some time pointing out all the amazing work that's being done using TMS and research here at HSC. Dr. Hager and I are working on the PREEMPT study, specifically the TMS part that's focusing on suicidality. Dr. Pirio Richardson, the OG TMS researcher here at UNM, who's doing work on dystonia with TMS. Andy Mayer and I have collaborated on using accelerated theta burst for mild TBI patients. Jim Kavanaugh and Jeremy Hogeveen in psychology department using TMS to actually probe and modulate brain activity to see how anhedonia symptoms and decision-making are influenced. John Houck used TMS to target the cerebellum to try to reduce alcohol cravings. And we've got a number of other folks who are sort of doing very interesting things with TMS. Joel Upston does modeling of the electric field and how that influences efficacy. Will Wiley, our new CL service psychiatrist, he's collecting circular RNA data in patients receiving TMS. and is deep in the weeds with analyzing that. Dr. Bott from Addictions is very interested to see how TMS might be applicable to substance use disorders such as methamphetamine. Andre Vakhtine at Mind Research Network and I are collaborating on a study using accelerated theta burst for long COVID and whether this actually modulates neuroinflammation markers. Dr. Villarreal at the Albuquerque VA we're halfway through a study of theta burst for PTSD. And Bin Nguyen is someone who's at the Center for Brain Recovery and Repair who's leading our work on FNIRS and how that might be able to inform how we deliver TMS. So super exciting to be involved in this work, particularly now that we have this fancy robot that helps us to place the coil exactly where we want it to go and you don't have to hold it yourself. So our clinical service and our computational neurosciences and precision therapeutics lab go hand in hand and work collaboratively to bring patients to our lab and also bring what we know in the lab to the bedside. So very happy to sort of present this to you. And I also just want to make a pitch for anyone who wants to be involved in our research. Please reach out to me. It's very, very sort of easy for residents and medical students to plug into our studies. Ideally, we're going to have every single patient coming in and getting TMS here at UNM involved in a research study of some kind and have a Center for Excellence for Precision Psychiatric Interventional therapies here. So that's my talk. Thank you very much for your attention. Happy to take any questions.
Thank you, Dr. Quinn, for your excellent presentation. I'll take advantage that I introduce you to ask the first question. And actually, in a couple of other comments, actually, the last couple of points that you brought, that is, again, remarkable. The fact that you've been collaborating with a number of faculty members, learners, not only in the department outside, which, again, talks about your collaborative effort. So that's applauded. And also giving an opportunity for our learners. We're going to be meeting with the group that has an interest in psychiatry, so that might be an opportunity. So let me take advantage and ask you the first question. You mentioned a study that was done elsewhere looking at treatment-resistant depression, and that a good number of those individuals actually responded. So in that study, or in that database, have they asked a follow-up question? As you've heard me say before, that in a treatment-resistant depression clinic, about 40% actually really have bipolar depression. So my question is, in that particular study, did they retrospectively looked at the patients and discover bipolar 1 or 2? Actually, some studies have looked at if you get collateral information, you will get the bipolar 2 first in that study. And then in your data sets, have we asked that question retrospectively? Is it really 40%? Dr. Quinn.
Thank you. So the studies, interestingly, the one at Stanford that first documented sort of accelerated theta burst could be effective, they did include bipolar disorder patients. There were only a handful. So whether the non-responders have bipolar disorder or not, I think the overall takeaway from those studies is that they generally were acknowledging those who had bipolar depression already, and it was a small number, but definitely still there. There was a study that came out from the Penn group, Yvette Chalene presented at this same conference I was at, that showed that accelerated theta burst in a randomized controlled trial was effective for bipolar depression. So that group has demonstrated that definitively. In our study that we did with you as a collaborator, right, we found an attenuated response to accelerated theta burst in bipolar depressed patients. And I believe that probably had to do with the level of medications that they were on. A number of them were on quite high doses of antipsychotics, which is, why I think maybe we saw that. So I think that there's still an opportunity for work to optimize it for bipolar
Yeah.
depression.
Yeah,
And
your point
to
about the
determine these predictors.
antipsychotics, your point about the antipsychotics definitely caught my attention, so it'll be good to review. Dr. Quinn, would you rather manage the questions
Oh, yeah,
instead
sure.
of me? Go ahead. Go ahead. Go ahead.
Sure. I see Natalie Price has her hand up.
I think Kevin was first, but I'll go next if that's good.
Okay, sorry, I didn't see Kevin's hand.
Yeah. Hey, thank you. I just had a quick question, Dr. Quinn. Um, I know we have a lot of these like initial studies that show this like amazing like response and remission rates. And I was curious what your experience has been as far as like, for example, you mentioned your patients from 2020 or 2023 and 2024 or other groups in terms of like having to implement some form of like either maintenance accelerated TB or theta burst or just repetitive TMS, and how often that's, you know, if that's actually being studied, and in your own experience, if how often you're having to implement that for some of these folks.
Yeah, thank you. The point about the early studies showing a remarkable rate of response and remission that doesn't necessarily pan out so ideally in studies afterward is definitely relevant here. Stanford saw anywhere from 80 to 90% remission, as does Downer in their 1D protocol. I can tell you that, despite our efforts to try to replicate that and others' efforts to replicate that were presented at the TMS conference, even in a naturalistic setting, did not get anywhere close to that. So, we're seeing more 60, 70% response, not 90% response. And I think that's absolutely related to our patient population that we're treating being more treatment resistant, having more comorbidities, having more socioeconomic and psychosocial stressors than the Palo Alto and metropolitan Toronto populations that were pulled into these studies. So my expectation is that the response and remission rates will still be high, but they will not be as high in those initial studies. We definitely see, to speak to your point about maintenance and relapse and retreatment, I think we definitely see that maintenance helps. Or continuation helps. So if they get 1 week of accelerated theta burst and then we continue them with once a day treatments afterward, that seems to clearly sort of enhance the prolongation of the effect. To what degree, I can't really sort of say right now because we're not doing it in a controlled fashion, but I can definitely say that there are some people who seem to relapse very quickly after the 1 week, and then we put them on maintenance and they get the effect back and it lasts for longer. We also see, the same statistics for relapse after the treatments stop that we see with just once a day treatments. So after 1 week of treatment, some people will go home and they'll have 2 years of antidepressant effect, and other people will have 2 months. And it's really variable, and we, probably related to treatment resistance and this whole idea of network plasticity or receptivity. So that's something that we're very interested to kind of maybe look at, is to sort of see what is sort of the duration of benefit for our patients before, having a neuroplastogen or before having retreatment and after we implement that. So
Cool.
yeah,
Thank you.
yeah, absolutely. Natalie?
Thank you so much. I was curious about with respect to the fMRI based targeting, is the scalp guidance analogous to FNIR's guidance? I was just personally curious and saw that someone was doing some of that work, and I was just wondering with accessibility for children and resistance to motion artifacts, if that has a role here at all, although I know the spatial resolution wouldn't be quite the same.
Yeah. Thank you for asking that. The scalp guidance is not using any functional indicator at all. It's really just based on anatomic location, based on scalp measurements. So we use the use of FNIRS would be very interesting. And I'm not sure that that's the direction that our research is going in right now, since we have access to fMRI. But if someone didn't have access to fMRI and they wanted to understand, maybe is there a more receptive area using FNIRS, I think that would be, a very interesting study to carry out. TMS is now approved for adolescents with depression. So that came out just a few weeks ago. Of course, reimbursement for TMS for adolescents hasn't quite kicked in yet, but we're hoping that that will quickly follow. And so then treatment of adolescents and young adults with depression with TMS can become much more widespread.
Thank you.
Yeah, sure. Dr. McQueary, good to see you.
Good to see you. Just a wonderful presentation. So my question, it probably piggybacks off of Kevin. I was kind of thinking about the duration of benefit, and which I think you did answer, but I guess what I was also curious about was I was just wondering if sort of like the nature of the depression changes, like does it become not so treatment resistant, perhaps more responsive to antidepressants or psychotherapy? And so that might just be anecdotal, but I'd just love to hear your thoughts on that. And then I was just curious about if it's just to hear if it's been used for anxiety, PTSD, things of that nature.
Yeah, thank you. Thanks for those questions. So it really depends on the patient how durable or how much they're sort of changed, how durable the antidepressant response is, and does their depression actually change to in some kind of meaningful way having had this TMS. I would say that the average durability is 6 months. And we tell people, while you're feeling better, please do everything that you can to sort of change your life, bring in sort of lifestyle modification, do all kinds of things, take care of all kinds of things that you normally don't have, have it in you to take care of. Because that, I think, will actually help you when you start to feel depressed again, maybe to avoid getting as bad as it was. So there's that. I will say that some people have this sort of revelatory experience with TMS where they're like, oh my gosh, I don't remember the last time I felt this way, and I didn't know I had this in me. So revealing that for them can be sort of, revelatory, and it kind of change the way that they sort of view their depression and view their sort of brain, and it gives them a lot more sort of or a lot less pessimism about what they're going through. So I would say that some people feel like they've been handed something back, like some kind of qualitative control over their life that they lacked. And even if the depression returns, it's not so hopeless for them because they did have this sort of experience. So I think that this kind of meaning making around what happened to them with the TMS can be really important, although we're not doing anything, systematically about that. So I hope that answers your questions.
That's helpful.
Angelina? Hey there.
Hi. Okay, I think this probably would have been done early on into like when we first started looking into TMS as a treatment, but I was just kind of curious, has it been compared to like more standard first, second line treatments for depression? And if so, like how far are we from getting it to be just more of a early line treatment, I guess?
Yeah, thank you for that. It's been a long time since I've looked at that early literature, looking at it, comparing it to antidepressants. So comparing it as a first-line treatment has kind of rarely been done. Most people come into a TMS study and they failed at least several antidepressants, much less 5, 10, or 15 like in our studies. And that's I think more an artifact of kind of the reimbursement climate rather than what's scientifically important to test. I think ideally TMS would be used before antidepressants to try to address this before it becomes highly treatment resistant. And I think that we would see actually better return on investment from doing TMS as a first line or second line treatment rather than waiting till people fail a bunch of antidepressants first. but it has been shown, to sort of be non-inferior and definitely, I think, in my mind, superior to antidepressants alone for depression. I just can't pull up the studies off the top of my head. And it looks like there's a question: how do we refer patients to TMS clinic? If you're internal, then you can just send a power chart message through Cerner to me, and I'd be happy to screen the patient and then determine kind of candidacy. So all you have to do is just reach out to me. If you're external, then sending a referral into our clinic, where we do the treatments, which is the CMDC clinic, is sort of the main there. You can also send it into the general psychiatry referral line and just designate, please send to for TMS with Dr. Quinn, and that'll work. And so we receive a bunch of referrals from outside as well as the VA for those patients. Dr. Vicente and then Dr. Villarreal.
Mine's really quick. So I was just wondering, having done like RTMS, I know with like that number of like, pulses, just with the RTMS, some patients complain at the MT of like 120 that it can be kind of uncomfortable. I was curious, how are the patients doing with like the theta burst multiple times a day?
Yeah. Thanks for that. In the 3D study, it looked like there was maybe a higher rate of scalp pain and headache from the theta burst. I would say that in our practice, we use the first few treatments to try to get people like titrated up to their goal. We don't start right at goal. And that helps a lot with getting people acclimated. So the sensation is very sort of aversive at first, but there's sort of rapid kind of habituation to it. So over those first few sessions, we were able to get people up to their goal 95% of the time.
Cool.
Yeah.
So, last question, Dr. Villarreal.
Yeah, I just actually have a quick comment. Thanks for the excellent presentation. This issue with cycloserine is fascinating. About 15 years ago, and there's something shared in the chat, there was a lot of interest in anxiety disorders in doing exposure, this idea that it would enhance learning and consolidation of learning during exposure, but it didn't kind of pan out over the time. But it's kind of interesting, fascinating that it's using TMS. Thanks.
It's a great case of old wine in new bottles, right? So bringing things back that we thought had kind of seen their time and their day, just goes to show it's never speak too soon.
So let's end with a comment from Dr. Delmore, which acknowledging involving our learners, working with them, and serving as a role model. Thank you, Dr. Quinn.
Thanks, my pleasure. Thanks all for your attention and for attending.